Hello everybody and welcome to Introduction to Lung Ultrasound for the Detection of Pneumothorax. We have no disclosures. Why learn lung ultrasound? Well, if you're an anesthesiologist in the OR, you may have this scenario. You are starting a long anesthetic. Just before placing the subclavian central line, you visualize lung sliding using ultrasound. Subsequent placement of the central venous line requires multiple attempts, but it is ultimately successful. You place the ultrasound probe on the chest again and rule out significant pneumothorax before proceeding with surgery with peace of mind. Chest X-ray and pneumothorax were recently compared in a meta-analysis in trauma patients. It was found that ultrasound has a high sensitivity that is higher than chest X-ray and a similar specificity for pneumothorax. 4 ultrasound artifacts are useful for the detection of pneumothorax. Number 1, lung sliding. Number 2, lung pulse. Number 3, B lines. And finally, lung point. We prefer to use the linear probe for pneumothorax detection, either the small linear probe you're using for your central line placement anyway, or the curvy linear probe. Less convenient is the phased array probe because it has less resolution. This photo illustrates the best starting position for the ultrasound transducer placement for the detection of pneumothorax. How does lung ultrasound work? The probe, which is placed upon the chest, emits ultrasound waves to the pleura. Here we see the parietal pleura and the visceral pleura. As the patient breathes, the visceral pleura slides on the parietal pleura and disturbs the ultrasound waves that return to the probe in a characteristic manner, producing the so-called sandy beach sign. We also note that there are ribs above and below the pleural interspace. So the first sign is lung sliding. Let's identify the important landmarks first. The probe is placed with the index mark towards the head of the patient. Slide the probe around until you've identified a rib above and below and the corresponding pleural space. That's the rib below and the rib above and the pleural space. If you're not sure whether you're seeing lung sliding in two-dimensional scanning, add M mode. M mode is one of the oldest ultrasound modes. It displays ultrasound reflections along one single line as a function of time. Here's the 2D image. In the scout picture, we can see the rib below and the rib above and the pleura. On the corresponding M mode image, we see the pleura again. Below the pleura is projected the sandy beach artifact. Above the pleura, the unchanging chest wall, producing a pattern reminiscent of waves hitting the beach. This is an image taken from a patient with a pneumothorax. Once again, we try to identify landmarks such as the parietal pleura. By the way, there is a similar line that is equidistant from the probe, twice as deep, and that is called the A line. We'll get back to that later, not to be confused with the pleural line. The M mode of this patient. First identify the parietal pleura, then find the corresponding echogenic line on the M mode image. Above that line are structures corresponding to the chest wall. And below the line we're expecting the sandy beach sign, but we do not see it. We also see artifacts that are emerging from very superficial structures that are more superficial than the parietal pleura. Here, and here, and here, and elsewhere. These are artifacts arising from the chest wall. They are caused by muscle and fascial sliding in the chest wall. Normal lung sliding rules out pneumothorax with a negative predictive value of close to 100%. However, lack of lung sliding does not necessarily confirm pneumothorax. Lung sliding may be absent in massive atelectasis, such as right mainstem intubation, ARDS, contusions, pleural adhesions in which the visceral pleura is adhesed to the parietal pleura. That's why the specificity for detection of pneumothorax in critically ill ICU patients may range from 60 to 90%. Bottom line is, lung sliding rules out pneumothorax, but if there is no lung sliding, we're not sure. Next sign is lung pulse. Lung pulse is a movement of the pleural line caused by transmission of cardiac pulsation. More simply, cardiac pulsations make the lung shiver, and that can be seen with M mode. Why use lung pulse? Even if you don't see lung sliding because of pleural adhesions, atelectasis, or even breath holding, lung pulse should still be present in the normal lung. Presence of lung pulse rules out pneumothorax. So let's say you're looking at this ultrasound on the right and you're not sure whether there's lung sliding. You just may not be able to recognize it. This happens to be a healthy individual holding his breath, so there shouldn't be much lung sliding. Let's use M mode to detect lung pulse and rule out pneumothorax in this individual. Here we've placed the M mode. First we look for landmarks, such as the pleura, corresponding to that white line on the M mode tracing. We notice regular rhythmic disturbances that are emanating mostly from that pleural line, and they repeat themselves in regular intervals. As a matter of fact, if we were to trace the EKG underneath this tracing, we would see that these are synchronous with cardiac pulsations. This is lung pulse. Here's a clinical case where lung sliding was useful. On the left, the 2D image. Here we see the pleural line. Here we see the M mode tracing, and we recognize the pleural line. We see disturbances that are emanating from the pleural line occurring in regular intervals. This is lung pulse. Since there is lung pulse, there is no pneumothorax. Let's look at a few practical examples. In this M mode image, we look for the pleura in the scout film, corresponding to this line here. We do see regular artifacts. However, these artifacts are not emanating from the pleural line, they're coming from more superficial structures. Here there's no lung sliding, there is no sandy beach, there is no lung pulse. We cannot exclude a pneumothorax. What about this case? Once again, we look for landmarks, ribs above and below the pleural line. Let's look for the corresponding line on the M mode. And we do see a sandy beach artifact below that line, and we see waves hitting the beach above it. In this case, we see sandy beach, and pneumothorax can be ruled out. Next case. Once again, identify anterior surface of a rib, the pleura, find the corresponding line on the M mode tracing. Once again, we're seeing artifacts that are emanating from structures that are superficial to the pleura. They're not emanating from the pleura itself. Here there is no lung sliding, there is no sandy beach sign, and there is no lung pulse. We cannot exclude pneumothorax in this patient. Last case. This is an image obtained with a phased array probe. I'm not really able to see the pleura well. It may be this line here. We do see artifacts that are stemming from very superficial and projecting to the bottom of the screen. There is nothing projecting from the suspected pleural line. In this case, we see no lung sliding, we see no sand beach, we see no lung pulse. We cannot exclude pneumothorax in this patient. Let's talk about some caveats with the lung pulse sign. Here's a patient, and I'm sure everybody can see the pneumothorax at the right apex. Here's a corresponding lung ultrasound. We can see that this patient is struggling to breathe. First, we see a rib, we see very likely a pleural line, but we see a lot of movement that's superficial in the chest wall. As a matter of fact, we see fascia and probably layers of muscle sliding one upon the other. Once again, the rib and parietal pleura, muscle and fascia sliding. Let's look at the corresponding M-mode picture. First, we find the pleura on the M-mode, but we also see lines that correspond to this fascia. See the artifacts? The artifacts are coming from superficial layers. Here's one. Here's another one. There's another one. There are plenty more. These movement artifacts are coming from the sliding chest wall muscles and fascia, not from the pleura. Here we see no sandy beach sign, and we cannot rule out pneumothorax. This patient may have a pneumothorax. We've seen that the patient who is struggling to breathe may be difficult to assess. Here's a case where the patient is struggling to breathe but does not have a pneumothorax. Both lung sliding and artifacts from the chest wall coexist in this M-mode tracing. On the left side we have the M-mode tracing, on the right side a enlarged picture. First we identify the pleural line, and we see that there is sandy beach sign coming from beneath the pleural line, so there is no pneumothorax. We also see that there are artifacts that are stemming from portions of the chest wall where muscle and fascia are sliding. These artifacts are originating superficially from the pleura. Diagnosis: there is no pneumothorax because lung sliding is present. Sensitivity of lung pulse is very high. The specificity of lung pulse is good but not perfect. The bottom line is, if you see lung pulse, you have excluded pneumothorax at that location. If you do not see lung pulse, then there may be a pneumothorax, but you're not sure. Third sign are the B lines. B lines arise from the visceral pleura as a result of increased pulmonary fluid. The utility of B lines. B lines can prove that there is no pneumothorax. B lines can be present even when there is no lung sliding, for instance in the setting of pleural adhesions. What is the theory? Once again in this cartoon we see ultrasound waves coming from the transducer to the pleura. The visceral pleura in this case has fluid collections. These can be interlobular septae that are engorged with fluid, such as in interstitial pulmonary edema. Deep to these artifacts are so-called comet tail artifacts, or B lines, that are supposed to progress to the bottom of the ultrasound screen. Let's look at an enlarged section of this pleura. In this enlarged section we see that ultrasound beams are entering the edge of the visceral pleura into the fluid collection and bouncing around a few times within the fluid collection before bouncing back to the ultrasound transducer. The transducer does not understand this and assumes that the returning signals are from deeper structures, thus creating the so-called comet tail artifact. Here we see a patient with B lines. We identify the pleura, and beneath the pleura are comet tail artifacts, the B lines, that progress from the pleura all the way down to the bottom of the ultrasound screen. B lines are caused by visceral pleura in the setting of pulmonary edema, atelectasis, consolidation, or any other interstitial disease. Caveat: subcutaneous emphysema may cause artifacts that look like B lines, but they arise from the chest wall superficial to the pleura. Bottom line, if you see even just one B line, you have excluded pneumothorax at the location of the transducer. The lack of B-lines does not allow you to make any conclusions regarding pneumothorax. The negative predictive value of a B-line is very good. It is 89 to 100%. The last sign we'll talk about is the lung point. The lung point represents the transitional zone where pneumothorax begins. On one side of this point, normal lung sliding can be detected. On the other, no lung sliding or lung pulse can be detected. What is the utility of the lung point? This is a positive pathologic sign, unlike lung sliding and lung pulse and B-lines. If you see a lung point, this means that you have detected a pneumothorax. Lung point allows confirmation of pneumothorax with 100% specificity. Caveat: lung point may be absent if the pneumothorax leads to complete collapse of the lung, preventing any contact of the lung to the chest wall. This photo illustrates how to find a lung point. First, scan over the anterior chest. If pneumothorax cannot be excluded by lung sliding, lung pulse, or presence of B-lines, gradually move the probe towards the lateral and inferior chest. Search for the first signs of lung contact. The intermittent appearance of lung sliding indicates that the border of the pneumothorax has been found. Let's apply this technique to our pneumothorax patient from before. Approximately at the zone indicated by this arrow, we see in this two-dimensional image a rib below and a rib above the intercostal space, and we see an unusual sliding artifact coming in from below and disappearing in synchrony with respirations. This is the lung point. This is intermittent appearance of lung sliding. This part of the pleura is just the parietal pleura with no visceral pleura. This part of the parietal pleura occasionally has visceral pleura slide on top of it, thus creating the lung point. Let's look at another patient. First, we look at the 2D image. We identify the rib and the pleura. Now we look at the M mode, which has been placed right at the edge of this rib and through the pleura. We identify the lines. First, we actually see a portion of the rib looking past. We can make out the pleura. And coming from just below the pleura, intermittently, we see lung sliding. We see small sections of sandy beach. This is the M-mode correlate of what we see on the two-dimensional image, namely the lung sliding from just underneath the rib at this point and becoming visible at the pleura. What's over here is pneumothorax. What's over here is the edge of the lung contact with the parietal pleura. This demonstration of lung point shows that this patient has a pneumothorax. Let's just look at a few other lung ultrasound images that you should be familiar with. This one illustrates a large pleural effusion. First, we look at the pleura. Then we see the anechoic portion. That's the pleural effusion. We see lung. Portions of the lung are actually collapsed or atelectatic. They look like liver. And then we see what corresponds to the diaphragm coming up from below, and beneath the diaphragm, the actual liver. Let's look at another image. Everybody can recognize this small pleural effusion, and we do see lung sliding underneath it. This patient does not have a pneumothorax. Let's look at more artifacts that you will encounter frequently. What about these horizontal lines occurring at great depth? First, we identify the pleura based on the anatomy. Here are the ribs, and here's the pleura. And then we see another line that is a fair distance from the pleura, and that is an A line. Let's take a look at where the transducer is placed on the skin. Notice how this distance here is about the same as this distance. Let's think about this in terms of the ultrasound waves. Ultrasound waves emanating from the transducer at the surface are traveling to the pleura, bouncing back to the ultrasound, and most of them are getting registered by the ultrasound probe. However, some of them bounce off the surface of the ultrasound probe back to the pleura a second time, and then bounce back to the ultrasound probe. The ultrasound probe does not know that these are waves that have been reflected twice. The ultrasound probe thinks that the ultrasound wave was sent into the body to a very deep structure and then bounced back. Therefore, it projects a line that is similar to the pleura at twice the distance, the so-called A line. A lines are not real structures. A lines also disappear when there are B lines. A lines can occur in both normal lungs and they can occur in the setting of a pneumothorax. So they do not help us distinguish a normal lung from a pneumothorax. Let's take a look at this image. I'm sure everybody can recognize the equidistant lines on this slide. Let's label these. First, the pleura. You may be able to see lung sliding at this point. Second, we see the first A line, and even deeper, we see the second A line. When you look at the surface where the transducer is placed, it becomes apparent that these lines are all equidistant from each other. They're reflections due to multiple bouncing back and forth of waves between the pleura and the transducer probe surface. How can these signs be used to diagnose pneumothorax? There is consensus stemming from the International Consensus Conference on Lung Ultrasound. This slide on the right was developed by this consensus conference. First, any lung sliding excludes pneumothorax at the location of the probe. Secondly, any B lines exclude pneumothorax at that location. Third, any lung pulse artifacts exclude pneumothorax at that location. When there's no lung sliding, no B line, and no lung pulse, and a lung point is present, the diagnosis of pneumothorax should be strongly considered. In the consensus paper, the quote is, "In extreme emergency, absence of any movement of the pleural line, either horizontal, which is sliding, or vertical, which is pulse, coupled with absence of B lines allows prompt and safe diagnosis of pneumothorax without the need for searching for the lung point." Why do they say this? Well, the reason is that lung point can be impossible to find if the lung is completely collapsed, as in inattention pneumothorax. On this schematic, we can see that if you see lung sliding, then you stop there. There's no pneumothorax. In case you don't see lung sliding, that may be due to pleural adhesions. You may still see B lines. If you see B lines, you do not have a pneumothorax. You can stop there. If you don't see B lines, you will look for a lung point. If you don't see a lung point, you can also look for a lung pulse. If you see lung pulse, there is no pneumothorax. If, on the other hand, you do see a lung point, then you have a pneumothorax. In other words, if you see lung sliding, or if you see B lines, or if you see a lung pulse, you do not have a pneumothorax. If you don't see any of these, but you see a lung point, you have a pneumothorax. Caveats for lung ultrasound. Lung ultrasound will detect even very small, clinically insignificant pneumothoraces. If your patient is stable but has lung ultrasound signs consistent with pneumothorax, consider pursuing other diagnostics such as chest X-ray or computer tomography per the standard of care at your institution. This pneumothorax may be small and not require any intervention. Any intervention may cause more harm than benefit. Beware of false lung pulse or false lung sliding in patients with sliding of muscles and fascia in the chest wall. This is more likely in the patient with respiratory failure. Beware of false B lines. such as in subcutaneous emphysema. B-lines must originate at the pleura and extend to the bottom of the ultrasound screen. Although the finding of a very lateral lung point may be associated with a larger pneumothorax, this association may not be valid in the setting of pleural adhesions. Finally, if your patient is unstable and no lung sliding, no lung pulse, and no B-lines can be located, then the likelihood of a pneumothorax is high. Do not waste time looking for a lung point in this situation, as the lung is likely to be completely collapsed without any contact to the chest wall. Given the appropriate clinical setting with a possible injury to the lung, your patient may have a tension pneumothorax. Prompt decompression of the chest should be considered at this time. This concludes our lung ultrasound lecture. Thank you for listening. Bye-bye.